everyone. I would like to welcome you to this session on PrEP in the real world. What are we learning? My name is Maria Prins. I'm from the Public Health Service in Amsterdam, here downtown. And we will have a presentation by 7 presenters of 5 minutes each. And afterwards, there is room for questions and discussions with the audience. In between, we don't take questions. We do that at the end. And it's my pleasure to introduce to you the first speaker, Sara Paparini. She's an anthropologist working at the Graduate Institute of International and Development Studies in Geneva in Switzerland. And for some reason, her presentation was not uploaded, so she has the challenge to present you by hand. Welcome.
Good afternoon, everyone. Sorry about the lack of PowerPoint. I'm here to present our poster, which is outside room E102 on this floor. The poster is called The Responsibility of PrEP and was written by myself, Will Natland, and Vinkim Nguyen. In England at the moment, there is no provision of PrEP on the National Health Service outside of a very large public health trial. However, the results of the PROUD trial, the PrEP trial, a randomized controlled trial, were announced in 2015, and the new public health trial has started in October 2017. So there were about 2 years in which PrEP was not really available formally in any way. And this has produced a phenomenon we call DIY PrEP. In 2015, different activists set up 2 fundamental websites. One is called I Want PrEP Now, and one is called Prepster. And these websites signposted people to buy generic PrEP online from pharmacies in various places outside of England. So together with some of the colleagues from Prepster, we decided to look at how we could deliver an intervention to support DIY PrEP users, so informal PrEP users, a peer-delivered intervention. And as part of this desire to design this intervention, and as part of also a broader ethnography that I am conducting on PrEP in England, we carried out a small formative qualitative study, which was made up of focus groups with London-based MSM, 20 of them. So this is a very small exploratory study I'm presenting here, to work out their views and experiences of sourcing and using PrEP do-it-yourself. The poster reports on some of the findings, which we're focusing on for the next 2 minutes, which is on the issue of responsibility. But we also have a paper coming out in +1, probably in the next month, which gives you a bit more of the results of this small formative qualitative study. So all really I wanted to say, the message is about responsibilities, that with PrEP we've come to think of responsibility as a very individual notion, individual self-care, individuals looking after themselves. But in talking with MSM who used DIY PrEP, it became apparent that it is not only a form of self-care and not a straightforward form of self-care, but it's also, they saw it very much as a collective form of care, how to reduce HIV and also how to educate other men about where they can find PrEP outside of the health service. So it was seen as a kind of community activity. And also they talked a lot about the responsibility of the state towards them as citizens, and how this was mediated by clinicians that had helped them find out that PrEP existed, but was also somehow neglected by the state, who was not able at that time to provide PrEP for them. So I guess my main point here is that DIY PrEP sort of widens the notion of individual responsibility of PrEP users to a collective and more political responsibility, and has brought back a renewed sense of health citizenship and activism in England. Thank you.
Thank you very much. I will move to the next speaker, and that's John de Witt. He's professor of interdisciplinary social science at the Utrecht University in the Netherlands, and also affiliated with the University of New South Wales in Sydney, Australia. And he will talk about attitudes regarding HIV, PrEP, and condom use.
Thanks a lot, Maria, and I will indeed talk about Melbourne to add another venue. I'll be talking about the Vic PrEP study, which is a small PrEP demonstration project that started in 2014, which was the first small PrEP demonstration project in Australia, and actually the first PrEP demonstration project without any sites in the United States. I have one disclosure to make. Gilead paid for the Truvada that was used in this study. So really, the focus of the Vic PrEP study was to look at interest of men with sex with men in PrEP, and also to look at any changes in sexual risk reduction practice, in particular looking at changes in condom use, which we've reported previously in a paper published in AIDS just last year. So what I will be talking about here is really looking at what can we say about the factors or the decision-making processes that influence and that shape men's use of condoms once they initiate PrEP. So we looked at a range of factors. So as I said, this was a small-scale study. At the time, we thought maybe interest wasn't going to be that big, but the places were filled before we started this study, as you would know. So the study has long since been replaced by a scale-up program called PrEP-X, and in Australia, PrEP is now available on the public subsidized system. So in Vic PrEP, we followed the men with sex with men for about 12 months, clinically, behaviorally, and what I'll be looking at is changes in condom use with casual partners over the period of the first year of the study, and looked at a range of factors that we thought might sort of give us a bit of a sense as to why men would use condoms or wouldn't use condoms. So this is a bit of a slide with a smallish font. But what it shows in the middle sort of column is univariable associations, on the right-hand side, multivariable associations. What this slide basically tells us is that over the period of a year, men started using condoms less, or quite a few men stopped using condoms and the frequency reduced. That happened within the first 3 months of the study and was stable afterwards. Wasn't related to anything to do with their age or education or country of birth or frequency of having anal sex with partners in the multivariable model. What was related in the multivariable model were really sort of men's attitudes. So what we saw was that the men who thought that HIV was a more serious condition or relative were more likely to continue using condoms, as were the men who thought it was very important for them to remain HIV negative. The men who thought that PrEP was really important for them to protect themselves from HIV infection were less likely to use condoms, and all the men who continued using condoms sort of experienced adverse impacts of that on their sex life. So which brings me to a couple of conclusions. So I suppose what we notice is that condom use is going down in men using PrEP. We've suspected that some studies have been published around that, and I think what's important to realize in that context, in these men were all very highly adherent of PrEP, so there was no increased risk for HIV infection among these men despite their reduced condom use. So but it does raise questions for us as to how we pitch and frame PrEP. Do we really want to continue pitching it as an additional prevention tool, or do we want to sort of acknowledge reality that men choose? And if we do that, how do we talk about prevention of other STIs? So the perceived seriousness, so the more men were, let's say, scared about HIV, the more likely they were to continue condoms, and despite probably any adverse effects they were experiencing. So what we see here is rather a complicated decision-making process or evaluation context where men take a number of issues into account when they make decisions about whether or not using condoms. And I think interesting issues or important issues moving forward are really sort of how do we promote STI prevention amongst men who stop using condoms. And from clinical colleagues, I hear that some men might be reappraising condoms as a way of preventing STIs. So that was really what I wanted to say in these 5 minutes, and do have a look at the poster. Thanks very much.
Our next presenter will be Mohammed Ahmed Hamoud. He's Senior Research Officer at the Kirby Institute in Sydney, Australia, and he will talk about the new MTV generation.
Welcome all. Today I'll be talking about PrEP use, PrEP as a harm reduction strategy amongst gay and bisexual men who engage in chemsex networks. To offer a very brief background, gay and bisexual men often use drugs to enhance sexual pleasure, which is commonly referred to as chemsex or party and play. Two drugs commonly used in chemsex are methamphetamine and Viagra. Methamphetamine to enhance sexual pleasure and Viagra to extend longevity or to offset the erectile dysfunction associated with methamphetamine use. Both of these drugs, together and separately, are both strongly associated with HIV infection. So that gives us this is where this question came in. What we're looking at is, are gay and bisexual men who engage in chemsex using PrEP to mitigate against the risk of HIV infection? With that, let me introduce you to the new MTV generation, using meth, Truvada and Viagra to have fun and stay safe. Each part of these drugs brings something to the party. Meth for sexual pleasure, Truvada for HIV protection, and Viagra to extend sexual intercourse. To answer the question, we used data from the Flux study, Australia's largest study of drug use among gay and bisexual men. Since the study launched in 2014, the combined use of meth and Viagra has been decreasing, but at the same time, a greater than 5 times increase in the prevalence of PrEP use. Overall, the use of meth, Truvada and Viagra has started to increase. It would appear that as PrEP becomes more available, those who are engaging in chemsex have since started using PrEP to reduce the risks of HIV infection. To explore what behaviours were associated with PrEP use among those who engage in chemsex, we compared men who used meth and Viagra to men who used MTV. Any behaviours we see here will be associated with PrEP use. So men who MTV were more socially engaged with other gay men. This would suggest that men who engage in chemsex are using PrEP to mitigate against these risks. Sorry, let me start again. This would suggest that Truvada is being used to... This would suggest that PrEP is being used... This would suggest that PrEP used is associated with more knowledge and access to PrEP. They were also more likely to be engaging in HIV risk behaviours. So they were also more likely to be engaging in risk behaviours. This would suggest that the Truvada use may be associated with risk reduction. We further compared the men who only used Truvada to those who used Truvada but engaged in chemsex. Any differences seen here are associated with engaging in chemsex and not Truvada use. Similar to the previous analysis, what we found was men were more socially engaged with other gay men. This suggests that a social influence and/or normalisation of the use of drugs with chemsex. And, not too surprisingly, they were also more likely to report HIV sexual risk behaviours. They were also more likely to be older. This suggests that any age differences seen comparing these two groups are probably specific to the use of Viagra. So what does all this mean? Incorporating PrEP into sexual and drug use practices offers a highly effective harm reduction strategy among chemsex networks. Peer networks may play an important role in normalising new prevention technologies in the same way that they appear to be normalising the use of other drugs. And finally, gay community peer norms and social connections play a strong role in drug use among gay and bisexual men, and these community networks can provide an opportunity to promote the use of PrEP. Thank you.
I would like to introduce to you Elske Horneborg. She's an infectious diseases specialist working at the Public Health Service in Amsterdam, and she will talk about hepatitis C among PrEP users.
Thank you, Maria. Indeed, the next 5 minutes I will speak about hepatitis C virus infections in the context of PrEP use. These are my disclosures. We did our research in the context of the Amsterdam PrEP project, a PrEP demonstration project for 376 MSM and transgender people. They have the choice between daily or event-driven PrEP use, and the study started in 2015. These participants were tested for hepatitis C virus infection by testing antibodies and/or HCV RNA. We tested them at baseline, and we found an unexpected high prevalence of 4.8%, and subsequently we tested them every 6 months. The study outcomes for this analysis are the incidence rates of HCV primary and reinfections, and the HCV genotype distribution and phylogenetic clustering. In this study, we diagnosed 12 hepatitis C virus infections, leading to an incidence rate of 1.9 per 100 person years. 6 of those were primary HCV infections. And in the figure on the left, you can see the incidence rate of primary HCV infections overall for the whole study group in the first year of PrEP use. We also disaggregated these data for daily PrEP users in red and event-driven PrEP users in blue. This is the first year, and we also looked at the second year of PrEP use. 6 infections were reinfections, leading to a very high incidence rate of 25.5 per 100 person years. Please note a markedly different scale on the y-axis. Here you see the overall incidence of reinfection in the first year, and again disaggregated for daily in red and event-driven in blue PrEP use, and in the second year of PrEP use. Here you see a phylogenetic tree of genotype 1A HCV infections. The red stars represent the MPrEP participants. The open red stars are prevalent infections at baseline, and the closed red stars are incident cases that we found. Moreover, the blue dots represent HIV-positive MSM, and the black is other non-related risk groups. And phylogenetic analysis revealed that 8 of the 9 HCV-1A genotype incident infections are part of 4 large MSM-specific clusters. And we see in those clusters both HIV-positive and HIV-negative MSM. To conclude, we show that MSM on PrEP are at high risk for HCV infection with an incidence rate of 1.9 per 100 person years. We see a high rate of HCV reinfections. And those incidence rates are comparable to those in HIV-positive MSM. The high degree of phylogenetic clustering between HIV-positive and HIV-negative MSM on PrEP suggests shared transmission networks. We promote routine HCV testing, prompt treatment, and interventions if needed for MSM starting with and using PrEP. Thank you.
Now we move to extension of PrEP programs among key populations, and this will be presented by Kirsten Jomond. He's a medical officer at the Center for Disease Control and Prevention in Atlanta, United States.
Good afternoon. My name is Gaston Jomond, and I will be presenting on the expansion of HIV pre-exposure prophylaxis among key populations in PEPFAR Global Program. And this is the data from the first year of implementation. Key populations such as men who have sex with men, female sex workers, persons who inject drugs, and transgender persons experience a disproportionate risk of HIV infection compared to other populations. We all know that oral PrEP significantly reduces the risk of HIV infection among HIV-negative persons with substantial risk behavior. PEPFAR, the largest bilateral funder for HIV programs globally, issued in 2016 a guidance on PrEP programming. The program data on the number of people newly enrolled on oral PrEP are reported quarterly by PEPFAR 36-country regional program. And for each quarter, the reported number are stratified by general population and key population. So what we did is that we computed the proportion of all new PrEP enrollee contributed by key populations versus general population, and we kind of compared the relative percentage change in PrEP enrollment for those populations between the first quarter and the last quarter of the first implementation year. So as you can see on the first table on the top, the reporting of PrEP is unpredictable. Out of 5 countries reporting PrEP enrollees, only 3 countries reported key populations on PrEP. And we had 5 out of 7 for the second quarter, 8 out of 13 for the third quarter, and 6 out of 9 for the fourth quarter. The figure below shows the enrollment of PrEP on the over time by general population and key populations. And what is noticeable here is that we see a really gradual increase among PrEP users, both for the general population and for key population. But what is important to note here is that this reporting is only half of the PEPFAR countries. If we look at the data that is not shown here, the percent increase from the first to the fourth quarter is exponential, especially for MSM. It's approximately 1,500% increase when you take the first to the fourth. So over the four reporting periods in the first year, PrEP enrollment increased steadily among both key population and general populations. What is important to note here is that the reported uptake was higher among general population than key population. However, the data were not queried for potential misclassification. It is possible that there were people enrolled in PrEP who did not disclose their KP status and therefore were misclassified in the general population group. However, we need to have specific efforts to streamline key populations PrEP scale-up by ensuring the accurate reporting and data quality. We also need to increase the demand creation beyond those 18 early adopter countries. We also need to do some advocacy with host government to fast-track PrEP services. I think in a nutshell, we may have been starting PrEP, on a gradual fashion, but it was a pretty successful one. So the next step would be to identify the most successful PrEP implementers, share the country's successes and best practices across PEPFAR. We also need to ensure adherence and retention among those who are still at substantial risk of HIV infection. And we need to continue to advocate for KP enabling environment to address restrictive KP national policies, and potential gender inequalities. Thank you.
Our next speaker is Mackenzie Cottrell. He is a researcher, assistant professor at the UNC Esselman School of Pharmacy in Chapel Hill in the United States. And he is going to talk about TDFFTC pharmacology in transgender females.
Thank you for that introduction, and to the conference organizers for allowing me to present these data on behalf of my co-authors. Transgender women are disproportionately infected with HIV, yet they've been underrepresented in HIV clinical trials. A large proportion of these women take female sex hormones such as estradiol and progesterone at very high doses in order to achieve a desired level of feminization. In cell culture, estradiol has been shown to increase a class of enzymes called nucleotidases, which, if located inside the cell, can decrease the amount of tenofovir disoproxyl fumarate, or TDF's, active metabolite, tenofovir diphosphate. If these enzymes are located on the plasma cell membrane, they can increase the TDF competitive substrate, deoxyadenosine triphosphate, or DATP. This balance is important for TDF's potency, and a shift in this balance in favor of more competitive substrate compared to active metabolite could impair efficacy. We conducted a small pilot study in order to understand whether TDF's pharmacology may be altered in HIV-infected transgender women on suppressive antiretroviral therapy and feminizing hormone therapy, and compared these women to cisgender women and cisgender men not taking hormones. We collected blood for plasma, serum, and peripheral blood mononuclear cells, or PBMCs, and rectal tissue biopsies at a single time point, and measured tenofovir and emtricitabine parent molecules in the plasma, tenofovir diphosphate, emtricitabine triphosphate, DATP, and DCTP in PBMCs and rectal tissue homogenates by HPLC-MS-MS. The remainder of this talk is going to focus on the rectal tissue data because we didn't really notice differences in plasma or PBMC drug measurements. We also analyzed steroid hormones in serum by enzyme immunoassay and HIV RNA and DNA in rectal tissue homogenates by digital droplet PCR. In this demographics table, I am disclosing that the cisgender male cohort was not fully enrolled at the time of this interim analysis. That's denoted by the asterisks. Our groups were well matched in terms of BMI and creatinine clearance, but our cisgender women were older, in part by design because we excluded premenopausal women from the cohort in order to avoid confounding due to highly variable and fluctuating female sex hormones. As expected, estradiol was highest among our transgender women in the serum, and testosterone was highest among our cisgender men. Here on the graph on the left, I'm showing the individual analyte concentration data with concentration in femtomole per gram of rectal tissue plotted on the y-axis, grouped by analyte on the x-axis, and cohort with cisgender women in red, transgender women in green, and cisgender men in blue. We did not discern statistically significant differences for any individual analyte using a non-parametric one-way ANOVA. However, when we looked at the ratio of tenofovir diphosphate to DATP, we observed approximately an 8-fold reduction in this ratio among transgender women compared to cisgender women and cisgender men. And one of our transgender women's ratios fell below the published EC90 value. We then wanted to explore whether female sex hormones might explain these pharmacologic differences, and I'm showing these data in the graphs on the left with tenofovir diphosphate to DATP plotted on the y-axis over serum estradiol and progesterone on the x-axis. The results of our non-parametric correlation analyses are overlaid on each respective graph and demonstrate that there was a significantly inverse correlation between the ratio and female sex hormone, meaning that individuals with the highest estradiol and progesterone exhibited the lowest ratios. Despite these pharmacologic differences, we did not observe a difference in HIV, RNA, or DNA in rectal tissues. These data are shown in the graph to the right, with HIV DNA in copies per million cell plotted on the left y-axis, and HIV RNA in copies per million copies of a housekeeping gene plotted on the right y-axis. So these data demonstrate that despite significantly lower tenofovir diphosphate to DATP in rectal tissue of transgender women, it does not appear that HIV replication is permitted in the context of fully suppressive antiretroviral therapy. These data also suggest a need to continue studying this question in HIV uninfected transgender women who are taking 2-drug PrEP therapy, in order to understand whether they might be more at risk for breakthrough infection during times of incomplete adherence. With that, I'd like to send out a special thanks to our study participants who donated their time and their bodies to this important research, and thank my funding sources.
Our last speaker today is Akarim Hiransuntugol. He's a medical graduate at the Thai Red Cross Center in Bangkok, Thailand, and will talk about drug-drug interactions among female transgender women.
So on behalf of the co-investigators, I would like to thank the conference organizers for the chance to present these data. First, I'm just going to talk a little bit of background of how we established our study. So I think it's an established fact by now that the PrEP is among the effective methods for HIV prevention. However, we began to have concerns over the efficacy of PrEP among transgender women. And this is because there are some studies that show us that the blood level of PrEP is lower among transgender women compared to non-transgender population. And I think that the reason to that can be categorized roughly into 2 possibilities. The first one is that transgender women did actually have good adherence to PrEP, but there was this unknown drug-to-drug interactions between PrEP and feminizing hormones. And but the second possibility is, and quite simply, is that transgender women did really have poor adherences to PrEP. Now, if that's the case, there's a survey suggesting that it could be due to the fact that transgender women prioritized the use of feminizing hormone over PrEP. So this comes back to the same issue in the sense that people are concerned over drug interactions between these 2 medications. So what we did was we established a study called IFACT to determine whether there really are these drug interactions between feminizing hormone therapy and antiretroviral agents, PrEP for today's presentation. And this is a 2-way analysis, meaning that we measure the effect of PrEP towards feminizing hormone therapy and vice versa. And the components that we used is estradiol valerate 2 mg per day plus cyproterone acetate 25 mg per day. And I need to emphasize that the feminizing hormone regimens can differ between each country. So let's look through the figure here. So 20 transgender women who never underwent orchiectomy and had never received injectable feminizing hormone therapy within the past 6 months were enrolled earlier this year. Now, at entry at week 0, what we did was we administered the feminizing hormone, both hormone, the estradiol and the CPA. At week 3, we measured the first intensive PK parameter estradiol. Now, after that, after we finished our blood test, we gave them PrEP. And 2 weeks later on, at week 5, we measured both the anti-PK parameter of estradiol and PrEP. So week 5 is kind of like the PrEP and hormones week. After we did the blood test at week 5, we briefly discontinued the feminizing hormone therapy in order for us to have the PrEP-only week at week 8. So week 8, we only measured the pharmacokinetic parameters of tenofovir, and then we continue the feminizing hormone therapy until the completion of 15 weeks to see the safety. So let's look at the results. The upper table shows the parameter of estradiol. So it compares week 3 and week 5. And again, week 3 is the hormones only week, and week 5 is the PrEP and hormones week. And overall, there were no significant differences in any of the parameters between the 2 weeks. Also, there was no significant change in the trough testosterone concentration that we measured at week 3 and 5 to kind of like be in an indirect measurement of the anti-androgen effect of CPA. So as a result, for the upper table, PrEP did not significantly affect the feminizing hormone levels. Now at the lower table shows the parameters of tenofovir. So we compare week 5, which is the PrEP and hormones week, and week 8, which is the PrEP only week. Here we can see that the geometric mean vary on the curve from time 0 to 24 hours, and the concentration at 24 hours of tenofovir was significantly lower at week 5 compared to week 8. So this essentially means that the plasma tenofovir exposure was lower in the presence of feminizing hormone therapy, roughly around 30% to be precise. So in conclusions, our study demonstrated lower plasma tenofovir exposure in the presence of feminizing hormone therapy, suggesting that feminizing hormone may potentially affect PrEP efficacy among transgender women. And equally as important, we also found out that the estradiol exposure was not affected by PrEP, which again is quite a concerning thing for transgender women to use both medications. Now, while our study has shown these previously unknown drug interactions between the feminizing hormones and PrEP, there are still some key questions that needs to be answered moving forward with this result. For instance, the first one, does this drug interaction occur in the cells or in the target tissue as well? Rectal tissue, for example, which is in most cases the first site of HIV contact. Secondly, does this interaction occur in the feminizing hormone regimens as well? And I cannot emphasize enough that feminizing hormone regimens can be different between each country. And last but not least, the reduction that we found with tenofovir, the 13% reduction. We don't know whether this 13% reduction in blood tenofovir exposure in the presence of feminizing hormones means anything regarding the preventive factor of PrEP among transgender women. Thank you.
I would like to thank all 7 presenters for the excellent presentations and also for keeping time. The floor is now open for questions. There are 3 microphones. Please introduce yourself and also indicate to whom you direct your question.
I'm Dr. Gilada from India. PrEP has definitely brought as a boon for the HIV prevention. But we found that it is bane for spreading of STDs, other STDs. Most of the practitioners which are prescribing PrEP, they are internal physicians. Initially, it started with a lot of STD specialists becoming HIV specialists. So they are not describing properly to the patients that apart from PrEP, they have to use condom regularly. What we are finding currently, that 3 infections or 4 infections are increasing more, and 2 of them are vaccine preventable, HPV infection and hepatitis B infection. And nobody is talking about those vaccines, and HPV vaccine is very cheap. And thirdly, syphilis, where penicillin is not available. Most of the places people are not using penicillin. So it's becoming very difficult to treat those cases which are getting STDs because of using only PrEP and not using condom.
Okay. Do you have a direct question to one of the panelists?
I think anybody can answer, because nobody has uttered STD on that.
Okay.
Well, look, since I talked about the behavior, I'm very happy to sort of kick off, because I think you're putting your finger into one of the issues that we're really looking at as to how to address STIs. In the context in which I work and many of us work, there is really sort of an emphasis on regular follow-up of people on PrEP, in particular to sort of address STIs. We might have to look at how we do that in other areas. So from my perspective, PrEP is being implemented, or should ideally be implemented, as part of a broader package of services that we offer. And I think what you're pointing at is that we may need to realize that more broadly. Yeah.
Thank you.
Okay,
Yeah.
Elske, go on.
I agree, and before this conference we had a 2-day conference on STI, really recognizing that there is a huge STI epidemic, and we need to combine efforts both for HIV and for STI prevention.
Okay, then we move to the back mic in the middle row.
Hello, my name is Nicholas Feustel. I'm a video journalist and PrEP activist from Germany. I have a question for Elske. I'm filming this session and I'd like to share this with the PrEP community, PrEP users on social media. Could you explain to the layperson, a PrEP user, what your findings are and what they mean for PrEP users?
You have to realize the context of our research. It was the first and for a long time the only PrEP demonstration project in the Netherlands. So the people we recruited really wanted to get PrEP and really had a lot of sexual contacts. Let alone, we found already at baseline a high prevalence of hepatitis C virus infection, much higher than in the broader HIV-negative MSM community. So the main point for all PrEP-using MSM from our side would be test, have a look. Don't forget to test for Hep C. It's not one of the common STIs that's always tested, but I think in this specific context we should learn more about what's happening. We should learn more about prevalence and incidence in different settings in different countries.
Thank you.
We move to the microphone on the right.
Yes, Brian Palmer, Gilead Sciences. This is a question for Dr. Cottrell. Two questions, really. One, did you measure any of the estradiol level changes, as in the last presentation? And two, your differences in the proportions occurred in the rectal homogenates. And so my other question is, do we think that that's the best place to measure? Or would it be other sites that are more directly intracellular, since that's where the likely mechanism of action is? Thank you.
Yeah, thank you for your question. So our population was already taking feminizing hormone therapy, so we didn't have the ability to measure pre-post, which would have been really nifty. In terms of the rectal tissue homogenates, there's a lot of debate out there about homogenate versus isolated CD4 cell within that rectal tissue biopsy. There are several challenges in being able to quantify and having assays sensitive enough in order to quantify tenofovir diphosphate in cells that are isolated from those homogenates. And so it's a trade-off. There's more risk of having a data set come back BLQ, which we can't really garner much from. But you know that you're looking at the cell type of interest within that biopsy if you isolate. We opted for the homogenates. Our lab has previously explored whether there's a correlation between tenofovir diphosphate in homogenates and isolated cells, and published that they did observe a correlation. That was for tenofovir gel. We've never been able to do that with oral tenofovir disoproxyl fumarate, but your limitation is noted.
Would be a great next step then for that.
Yeah.
Okay, go ahead.
Thanks for great presentations. Renzo Scheer from Chicago. For the last two presenters, Dr. Cottrell and Dr. Baran-Sutikal, you seem to be saying similar things about the potential pharmacologic decrease in the presence of hormones. For Dr. Cottrell, did the dosing difference, could that explain why you found no difference in plasma where the second study did? And then if you would both just think of the implications for the use of PrEP in transgender women, how do you translate this for those who are using PrEP?
Can I start? Yeah, so I think that my study is very small. It was a pilot study to generate data to support the need to further explore this. It is very possible that my lack of a finding in blood is simply that the 13% difference that was observed in the TIE study wasn't enough to come out as a difference in my NO4 versus NO4 versus NO2. So I, would not rule out my having made a type 2 error in blood measurements. And then the second part of your question was, could we put this in context? Is that correct? The messaging. I think in terms of messaging, we have clinical trial data that suggests that PrEP works in the clinical trial space in transgender women. We're working now on messaging around how many doses of PrEP do you need to take to be protected, and there are some models out there suggesting in men who have sex with men that 2 to 4 doses a week might actually be protective. I think in light of these data, we need to start considering whether that messaging also applies to transgender women who in these clinical trials typically get lumped in with men who have sex with men. I'm concerned that maybe there are some slight differences that mean that we need better adherence messaging for transgender women.
Okay, so thank you for the question. Well, I think for your first questions, I think the important thing is that the study design between the Professor McKenzie's study and mine is very different, because mine used kind of like the self-control, because the participants, all transgender women, are there controlled by themselves. We just have a longitudinal and off and on of the hormones to measure with hormone and without the hormone. And also, Dr. McKenzie's study is a comparison between each gender. Right, so it's quite different from the study design that we did. Now, for your second questions, this is a very important question that we actually have this question right away when we saw this result. I will try to make it like 2 parts of it. So the first part is that the good thing is we can confirm that PrEP should not affect the level of feminizing hormone therapy, in which studies have shown that, suggesting that transgender women may prioritize feminizing hormone therapy because they are scared of this interaction. So I think we can be quite certain about that okay, you can use both of them, and your feminizing hormone level will not be suboptimal if they use it with good adherences. Now, for the second part of it, the 13% reduction in blood tenofovir exposure, this is very tricky. So there really is, from our study, there really is a reduction in it. But as I said, we don't really know if 13% reduction means anything at all. There are several medications, but most of the hormones and drug interaction study are in women usually. And I happen I remember quite frankly that there are studies that okay, there are some interaction that decrease some of the ARV by even more than 13%, and they did not show any significant in the virological suppression. But again, it's an ART, not for PrEP. So it's a little bit tricky right now to communicate these results. But what I can tell you that I think we should be frank with it. So be honest that okay, we see the reaction, but we don't know it yet whether it's going to be important or not. However, just kind of a little bit of in detail of our studies, that the week that we found the blood tenofovir level reduction, the week that we found that, even the reduction level, the mean level of it is still reach the target tenofovir level for PrEP. Okay.
Okay, thank you. We will move to the middle microphone.
Yeah, Ulrich Kastenbauer from Germany. I have another question regarding the PrEP data on the hepatitis C cases. Did you look into other risk factors in the incident cases, drug use, group sex, anything?
We still have to do that.
Hello, my name is Amoli Juliet from Uganda. I'm representing the ICW, International Community of Women Living with HIV, Eastern Africa, and Athena. But I'm a land ambassador. Young Women Lead Evidence Advocate Research and Network, supporting the effective rollout of PrEP by ensuring that young women needs, priorities, and preferences are met in all diversities. So my major, it's so sad that we don't have a representative from Uganda, but I just wanted to know whether it's possible for PrEP to be a contraceptive for the young women to reduce on the high rate of pregnancy and also on the reduction of HIV prevalence. And also I wanted to, you talked about the with the male side, you didn't talk about the side effects. Aren't there any side effects in the research? No one talked about it. That's all I wanted to know. Thank you.
Somebody who would like to add something? Yeah, go ahead.
So first of all, PrEP is an antiretroviral drug used to prevent HIV acquisition. So PrEP is not a contraceptive. Now, what was the second question?
Okay, we go to the...
Oh, if you can combine it with...
Yeah, my question was like, is it possible for it to be a contraceptive? Okay, like with research, is it possible for scientists to combine it with, when it's one pill, but
prevention technologies are definitely on the radar. They are being developed currently, but they're all in sort of the early development stages. Nothing's made it to clinical trials as of yet, but some of the PrEP implants that are being explored are considering adding in contraceptives for that concern that you voice.
Yep, Dr. George Forgan-Smith. I'm a HIV clinician and PrEP prescriber in Melbourne, Australia. A twofold hormone question. With regards to the precarious levels of tenofovir in the rectal mucosa for our trans clients, does this mean that you would not recommend intermittent dosing for this group of people? And also, maybe an overflow question for Mohammed would be, if we have people who are using larger doses of testosterone steroids in MSM, with the aromatization of the testosterone, could that affect their tenofovir levels as well?
Okay, so I'll start, because I'm pretty sure that was to me. I didn't hear the beginning. But so I would be careful about absolutely not recommending intermittent dosing in this time where to date we've got my pilot study that's suggesting lower tenofovir diphosphate to DATP in rectal tissue mucosa. But in the coming year, I think more studies are going to be reporting on tenofovir diphosphate concentrations in those transmission sites. And with that coming data, I think that we'll have a more clear answer to your question. I think that it would be fair to share with a transgender woman that there is this potential, and perhaps, until the new data comes out, daily dosing may be a better strategy. But I guess I would caution against. I'll let anybody else jump into.
To be completely honest, your question's well beyond my expertise. The Flux study does collect data on steroid use, PrEP use, and other drugs. Whether we can see PrEP efficacy works along with steroid use. I don't know if anyone else can answer that question.
Okay, thank you very much.
Thank you very much. My name is Nganyiso Kambu from Swaziland. I'm actually also working in Swaziland demonstrating the use of PrEP in the country. But my question is to the gentleman who actually presented on the reduced use of condoms when people are using PrEP. I just wanted to actually find out and have a clear on how the messaging is passed. Was PrEP actually brought as an additional prevention method? Because like for us, we're trying to target maybe to bring the message in the sense that those people who are struggling in using condoms, because one way or the other, some people are failing to use condoms for different reasons that are best known to them. So how do we bring PrEP across? Because for me, I think it is key in terms of how we message, because reality is that we don't have a best prevention method like condom so far, but the reality is that people still are not using condoms 100%. So I think we need to actually balance the messaging. I'm not so sure in this study how the messaging about PrEP is brought about versus condom. And also secondly is to the one who actually presented. Sorry, I wouldn't remember the names and I can't see there from a distance. And also the one who reported about actually identifying the key populations and general populations, those who are coming for PrEP. How is this done? Is it in general facilities? Is it self-reported by KPs? And which setting exactly? Is it the KPs who will actually report themselves that they are KPs, or the healthcare workers are able to identify them through history taking? Because it's one of the challenges that we have for us to identify, because like in Swaziland, we are implementing PrEP in the general population using the risk assessment, whereby anyone comes to the facility, and if they are actually at relative risk, then they can be actually offered PrEP. So I want to know how we identify the key populations versus general population.
I think the questions are addressed to John and to Gaston, so go ahead.
Thanks very much for your first question around the messaging and condom use. I think you put your finger right sort of where many of us are currently sort of thinking. So the messaging, so the formal messaging is that condom or that PrEP is an additional prevention method, so that condoms do have a place in HIV prevention, at least in the early days where we started this study. I think the other layer to your question, and you sort of answered it yourself, is that indeed, certainly in the MSM, who were very interested in PrEP in the early days, and that might change later on, are the men who were experiencing challenges or were not too keen on using condoms from the start. So the issue there is that PrEP for them was an important additional and perhaps also alternative way of preventing HIV. And I think the word frank has been used quite a lot in this session, and I think what I was getting at is whether we want to continue with that message that PrEP is an additional HIV prevention strategy, or whether it is an alternative HIV prevention strategy whereby we propose a package of services that also takes into account the STIs. And I think for many of the users that would be a much more realistic way of looking at PrEP. But I do believe there is that issue. I mean, there is the broader issue of what role do condoms have in HIV prevention. That depends, I think, quite substantially on the context in which we're working, the key population we're working with, the geographical area, the resources available. So I think I'm not going to answer that question, but I think it is one of the major questions that as a HIV community we need to be looking at as to how we are going to go about this. And it's ultimately a policy question, a preference question, and maybe even ultimately a political question.
So regarding your question about how we classify key populations, we do it several ways. We have a number of vertical programs, which are, MSM clinics, sex workers clinic, where it's pretty easy to classify. But and we all know that not all key populations, attend those vertical programs. So we have developed a classification tool for general public facilities where we are able to classify key population. But we need to have in mind that, based on the stigma and discrimination of those facilities, you have some key populations who do not disclose. So it is likely that, the data that we show may have some misclassification. And that's the reality of the real world.
To keep time, we have time for the last question. And maybe the last, if you have a very short question as well. Okay,
my one is
you.
very
Yeah.
short.
Okay.
Thank you so much. Good afternoon. I'm Dr. Thembi Xulu from South Africa, Johannesburg. And I've got a question for Dr. Jamon from the CDC. And I think at the end of your presentation, you highlighted the importance of supporting national policies to create enabling environments for key populations to access PrEP. Yes. I think from a funder's perspective, can you just tell us how you align the PrEP targets for the implementing partners to the national policies that are not quite enabling? Because sometimes we do find ourselves not able to deliver on the targets that we are given because the social justice environment is not enabling. So what is it that you are doing to support that? Thank you.
So first of all, what we sort of promote is first the advocacy, to the government for those policies. But one of the things that we do at our level that we can actually manage is we have done a range of key population sensitization training among our healthcare workers to sort of streamline that enrollment of PrEP because they understand what are the needs of key populations. And on another level, on a political level, that's something that the head of PEPFAR does with host governments. But so there is that, those two pieces, the high level advocacy, but we also do what we as healthcare professionals can do, in the field, and that's with healthcare workers.
Okay, the last question, I hope it's a short question.
Okay, I'll try and make it short. It's for Elske. Those certainly are astoundingly high hepatitis C reinfection rates. And may just reflect the fact that we now have, firstly, a cure so people can get reinfected, and also that positive and negative are now mixing because of PrEP. What should we do about it, basically? That's to keep the question short.
Thanks for the question. What should we do about it? Well, I think it's three things. One is tests. Two is everybody who is diagnosed with an hepatitis C infection should be referred to treatment, which is, and it should be available in all countries, ideally. And the last thing is that we really need to know more about interventions, behavioral intervention, other types of interventions to prevent reinfection, because that's really worrisome, the high reinfection rate that we found in our study.
Okay, thank you. I'm going to close the session, but before I do, I would like to thank all presenters for the excellent presentations.